Hello, people, and welcome to Med Novice, where we make tough medical stuff make sense. And the topic for today's discussion is amyloidosis, right? So, what exactly amyloidosis is? Amyloidosis refers to the deposition of amyloid in the extracellular space, right? Now, what amyloid is? So, amyloid is basically a misfolded protein. So it's a misfolded protein, and you will see usually it deposits in the extracellular space. Right. Now, multiple proteins can deposit as amyloid, and some of the features you will see regarding those proteins is, first of all, they will be in the beta plated sheet configuration. They will be in the beta plated sheet configuration. Second, they will be stained by Congo red, right? They will be stained by Congo red. And the third thing is they will show apple green birefringence. They show apple green birefringence under polarized light. Right. So, amyloidosis refers to the deposition of this misfolded protein in the extracellular space, and multiple proteins can form amyloid, and the basic characteristics you will see with amyloid is that it will be in the beta plated sheet configuration. It will stain by Congo red, and it will show apple green birefringence under the polarized light. Now, another important point is that amyloid often deposits around the blood vessels, right? Now we will be moving to the classification of amyloidosis. So the classification is quite simple. Amyloidosis can be either localized or systemic, right? Or you can say diffuse. So localized amyloidosis is when the deposition is restricted to a single organ or tissue, whereas in case of systemic amyloidosis or diffuse amyloidosis, we see that the deposition is across different organ systems or multiple organs basically, and it is not localized to a single organ. Now we will be discussing localized amyloidosis afterwards. First we will be discussing the systemic amyloidosis. So systemic amyloidosis can be classified further into primary systemic amyloidosis and secondary systemic amyloidosis, right? So first of all, coming to primary systemic amyloidosis, what we see here is the deposition of AL amyloid, right? So in case of primary systemic amyloidosis, there is deposition of AL amyloid, wherein AL refers to amyloid light chain. So as the name is clearly indicative, this AL amyloid will be derived from the Ig light chain, right? The immunoglobulin light chain. So what happens is basically in the plasma cells, what we usually see that the heavy chain is to light chain ratio is 1:1. But here what we will see is due to plasma cell dyscrasia, the light chain will be overproduced, right? The light chain will be overproduced, and this will lead to the formation of AL amyloid due to the misfolding of the light chain, and this AL amyloid will be depositing here and there, right? So this was the primary systemic amyloidosis. Now we will be moving to the secondary systemic amyloidosis. Here we see the deposition of AA amyloid. Now what happens is that whenever the body undergoes inflammation, then there are some substances in the body referred to as acute phase reactants that are indicative of inflammation, right? there can be positive acute phase reactants and there can be negative acute phase reactants. So whenever inflammation happens in the body, the positive acute phase reactants go up in their level, and whereas negative acute phase reactant levels fall down, right? So we have a positive acute phase reactant known as serum amyloid A. Serum amyloid A. This is a positive acute phase reactant, right? So whenever you will see that there is excessive production of this serum amyloid A, it will lead to formation of AA amyloid, right? So wherever you will see that inflammation is happening, there the SAA level will go up, right? This is also referred to as SAA. So the SAA levels will go up, leading to the formation of AA amyloid, which will be depositing here and there in the body. So what are the basic chronic inflammatory states you can see? For example, it can happen in case of lupus, it can happen in case of rheumatoid arthritis, it can happen in case of Crohn's disease, and multiple other chronic inflammatory states. And also it can happen in case of malignancy, right? Malignancy can be seen as a chronic inflammatory state, and there you will see the level of SAA goes up, leading to the formation of AA amyloid, whose deposition will lead to secondary amyloidosis, secondary systemic amyloidosis. One another important case wherein you see secondary systemic amyloidosis or the deposition of AA amyloid is in familial Mediterranean fever, right? So this is one another case where you can see deposition of this AA amyloid. And what happens here, this is autosomal recessive disorder. This is autosomal recessive disorder, right? And what happens here is that the neutrophils are not functioning properly, right? There is dysfunction of neutrophils, and due to which there is an attack of acute inflammation which is being created, right? The neutrophils get activated. Now there is no infection to initiate that acute inflammation, right? But due to the neutrophil dysfunction and activation of the neutrophils, an attack of acute inflammation is being created, right? And due to which you will see the patient will present with episodes of fever and acute serosal inflammation, right? So the patient will be presenting with episodes of fever and another thing you will see is acute serosal inflammation. Acute serosal inflammation, right? Now if this acute serosal inflammation happens in heart, then it mimics MI, right? Then it will mimic myocardial infarction. Whereas if it happens somewhere in abdomen, then it will mimic acute appendicitis. Acute appendicitis. So this was the case of familial Mediterranean fever, wherein there was a neutrophil dysfunction which led to episodes of fever, or basically an attack of acute inflammation, and also acute serosal inflammation, wherein if the serosal inflammation happens in heart, it mimics myocardial infarction, and if it happens in abdomen, it mimics acute appendicitis, right? Now talking about the general clinical findings of amyloidosis or systemic amyloidosis is, the first thing is that kidney is the most commonly affected organ. Kidney is the most commonly affected organ. Now as kidney is the most commonly affected organ, there will be deposition of protein in the kidneys, misfolded proteins in the kidneys, and what you will see is proteinuria that may be indicative of nephrotic syndrome. Right. Another thing what you can see is restrictive cardiomyopathy. So what happens here is that the heart is not completely filled, right? It is not getting properly filled, and it is due to some restriction, and the restriction is due to less compliance or less elasticity or bendability of the heart walls, right? The cardiac wall we are referring to here. And obviously if the amyloid will be depositing within the wall of heart, then the compliance of the wall of heart will go down, due to which restrictive cardiomyopathy can happen, right? Another thing what you can see here is tongue enlargement. And also you can see thickening of wall of bowel, thickening of bowel wall, right? And if the bowel wall thickens, what we will see is malabsorption, right? Malabsorption. So the patient may present with diarrhea basically in such cases. And coming to the fourth and final thing what you can see in case of amyloidosis is hepatosplenomegaly. Hepatosplenomegaly. So these were the generalized clinical findings of amyloidosis. And now coming to the diagnosis of amyloidosis, it will be requiring tissue biopsy, and the easily accessible targets for tissue biopsy to diagnose amyloidosis are abdominal fat pad and rectum, right? So easily accessible targets are abdominal fat pad and rectum. This is for the tissue biopsy to diagnose amyloidosis. And if any organ is being damaged due to amyloidosis, in that case what we need to understand is that amyloid can't be removed, right? So the only solution is transplantation of that organ. Now we will be moving to the second part of our discussion, and that is localized amyloidosis. So this was all about systemic amyloidosis. Now we will be moving to localized amyloidosis. So in case of localized amyloidosis, as the name is indicative, we will see that deposition is restricted to a single organ or tissue, right? Now we will be discussing multiple cases or multiple examples of localized amyloidosis, wherein the first one is senile cardiac amyloidosis. And the second one we will be discussing is the familial amyloid cardiomyopathy. We will be discussing many more cases, but these two are quite related, right? So as the term itself is indicative, senile will be referring to old age. So in case of patients with more than 80 years of age, you will see, or basically in individuals more than 80 years of age, you will see that 25% of them are having senile cardiac amyloidosis. Now what happens here, you have something called serum transthyretin, right? So you have this thing called serum transthyretin. This is the second most common protein that is present in blood. Now this will start depositing in heart, right? This will start depositing in heart, and if it is non-mutated, right, and presenting in usually in patients more than 80 years of age, then that will be the case of senile cardiac amyloidosis, wherein whereas if you will see that the serum transthyretin that is getting deposited in the heart wall or the cardiac wall is mutated, then that will be the case of familial amyloid cardiomyopathy. Now another important thing is that senile cardiac amyloidosis, this is usually asymptomatic, right? And whereas familial amyloid cardiomyopathy, this will lead to the deposition will lead to restrictive cardiomyopathy, as we discussed previously, right? So this will lead to restrictive cardiomyopathy, wherein the compliance of the heart wall will go down, and due to which there will be improper filling of heart, right? And another important fact regarding familial amyloid cardiomyopathy is that 5% of African Americans carry the mutated gene, right? So 5% of African Americans carry the mutated gene, right? So this was the discussion about senile cardiac amyloidosis and familial amyloid cardiomyopathy. Now we will be moving to the third case of localized amyloidosis, and that is type 2 diabetes. Type 2 diabetes, or basically non-insulin dependent diabetes mellitus. So what happens here is that there is resistance to insulin at the level of skeletal muscle and adipose tissue, right? Now pancreas will be releasing excess insulin. So pancreas releases excess insulin, and there is resistance to the insulin. So what happens as a result is that a byproduct is formed due to this excess insulin, and the byproduct is known as amylin. So the byproduct is known as amylin, and this amylin is a misfolded protein, and this will be depositing in the islets present within the pancreas, right? So it deposits in the islets present within the pancreas. So this is how you can see localized amyloidosis, wherein the amyloidosis will be happening in pancreas in case of type 2 diabetes mellitus, right? Now coming to the fourth case of localized amyloidosis, you can see localized amyloidosis in Alzheimer's disease, right? And here you will see the deposition of A beta amyloid. So there is deposition of A beta amyloid within the brain, and resulting in formation of amyloid plaques, right? And this A beta amyloid is derived from the beta amyloid precursor protein, right? So the beta amyloid precursor protein is the source of formation of A beta amyloid, and the genes for this protein, this precursor protein, is present on chromosome 21. As it is present on chromosome 21, what we see is that in the individuals having trisomy of chromosome 21, that means the individuals having Down syndrome, there you will see excessive production of this beta amyloid precursor protein, right? Due to which there will be excessive formation of A beta amyloid, resulting in deposition in brain and formation of amyloid plaques. And second thing, you will see in those patients of trisomy of chromosome 21 is early onset Alzheimer's disease. Early onset Alzheimer's disease, right? It is due to the trisomy of chromosome 21 on which the precursor protein genes were present, and as their levels go up due to misfolding, there is formation of A beta amyloid, and due to which we will see early onset Alzheimer's disease in case of Down syndrome, right? Now coming to the second case of localized amyloidosis, and that is dialysis associated amyloidosis, right? So what happens here is you have something called beta 2 microglobulin, right? Beta 2 microglobulin. Now, what exactly this beta 2 microglobulin is? See, you have MHC1 having a transmembrane domain and an extracellular domain, right? And the structural support to these two domains is given by this beta 2 microglobulin. Now, when a patient is under dialysis, this beta 2 microglobulin, this does not get filtered well, right? Now, as it does not get filtered well, there is accumulation of beta 2 microglobulin in blood, right? So there is accumulation of beta 2 microglobulin in blood, and this will result in deposition of beta 2 microglobulin in joints, right? So the amyloidosis here is localized to joints due to the deposition of beta 2 microglobulin in the joints, right? And this was due to less efficiency of filtration of this beta 2 microglobulin when the patient is under dialysis. So this was a simple case of dialysis associated amyloidosis. And now moving to the final example of localized amyloidosis, that is medullary carcinoma. Medullary carcinoma of thyroid, right? So what happens here is there is tumor of these cells called the C cells within the thyroid, right? Now there is tumor of these C cells and their normal function is to secrete calcitonin. Now as there is tumor of C cells, what we will see is overproduction of calcitonin, right? There will be overproduction of calcitonin, and this overproduced calcitonin, which is a protein hormone basically, will deposit within the tumor itself, right? So this overproduced calcitonin deposits within the tumor, and obviously it misfolds and gets deposited, and this will lead to amyloidosis being visible in case of medullary carcinoma of thyroid, right? And the characteristic of amyloidosis here is, the characteristic that you will see on the slide is that you will have tumor cells. You will have tumor cells in amyloid background. When you will be seeing the slide of thyroid, there you will be seeing that there are tumor cells that are present in an amyloid background. And with this we conclude the discussion on localized amyloidosis, and we conclude the discussion on amyloidosis. If this video helped you, don't forget to like, share and subscribe. This is Med Novice, learning medicine the simpler way. Thank you.